How about now? Can
Yeah,
you
I
see
can
it?
see that now.
You can. Okay, good. All right. So here's the equation, or not equation sheet, but information sheet that you're going to have available on the exam. Okay, and I think you have access to this, and if you don't, let me know. So that you have what you're not going to have. You don't get like your steady state or any of that stuff. Like, you should know those equations. But you need all this stuff that's drug specific for theophylline. Okay. Set this up. Sorry. All right. So the first question you had is OW is a 50-year-old, 70-kilogram man who's 5'10" tall. He's got chronic bronchitis, considered to be severe COPD. He needs therapy with theophylline. This doesn't always make sense, of course, but we're just using it as an example to practice doing these kinetics equations. So he smokes 2 packs of cigarette a day. He also has severe COPD. So we're going to start keeping track of the things that might affect the clearance of theophylline. He has normal liver and heart function, so that's good. Has hypertension. He's on ipratropium, salbutamol, and fluticasone inhalers. I don't think any of those should affect theophylline. He's on lisinopril and hydrochlorothiazide for his hypertension. And he was started on 500 milligrams BID of theophylline, PO. So his dose rate is 1,000 milligrams of theophylline per day, right? 2 weeks later, he stated that he has restlessness and double vision problems. So you suspect these to be theophylline dose-related side effects and send him to get his theophylline concentration checked. It was 30 milligrams per liter. So we know that the therapeutic range is 5 to 20, and he's at 30. So yes, this could be a case of theophylline clearance, or I'm sorry, theophylline related side effects. So what's the clearance in OW? Now, if I didn't tell you all this stuff and you were going to be starting on a new regimen, you would use this fact that he's smoking and he's got severe COPD, and those would be the only things that would really affect his theophylline clearance. So we could come up with a recommended dosing regimen, couldn't we, from this information here? But I'm taking you past that, and you now know that he was recommended to get 500 milligrams BID, or 1,000 milligrams a day of theophylline. So he started on 1,000 milligrams of theophylline and has a concentration of 30 milligrams per liter. So what's his clearance? Well, this is a pretty straightforward problem. We know CSS average is equal to salt form times bioavailability times dose rate all over clearance. We know that the salt form in this case, since he was given theophylline, not aminophylline, is 1. And we also know, if we look here, that the bioavailability is 1. So these things are both 1, which makes our lives easier, doesn't it? We also know that his dose rate was 1,000 milligrams per day of theophylline. We don't know the clearance, and that's what we're trying to figure out. But we know when he was getting 1,000 milligrams per day that he had a resulting concentration, and it was 2 weeks later. So I think we can be pretty confident that he's at steady state, and he has a CSS average at steady state of 30 milligrams per liter. So we can solve for clearance because there's only one unknown here, and that's clearance. Now, we're probably going to want to change this to hours, but we can do that at the end of the problem, because I have it in liters per hour, not in liters per day. But so we just have to plug and chug this, right? So 1,000 divided by 30 is, the clearance is 33.3, And this is milligrams, so this is in liters per day, isn't it? You guys follow me okay on that?
Yeah.
So if we need to change this to liters per hour, in one day, there are 24 hours, yes? So those days will cancel and we'll have liters per hour. So we have to divide that by 24. And so clearance is 1.38, or if we're rounding here, because it's 3.88, if we're rounding to here, it would be 1.39 liters per hour. Okay? Not hard. If I asked you what it was in liters per day, it would be 33.3 liters per day. Now, is everybody good with that?
Yeah, I do have a quick question. For
Yeah.
the exam, are we going to be able to use our whiteboards and calculators, I
Yes.
hope?
Yes, I better tell Dr. Waldschmidt that, but yeah, because these are complex equations.
Yeah, I don't think I'd be able to straighten it all out in the notes.
I sure couldn't either. So I'm sorry. Thank you for reminding me that. I gotta let that. I'm gonna write myself a note here. Because you have to do a little calculating for CF too, I think, for me. All right, what if this wasn't the question? So we're just gonna do some practicing here, okay? What if it, wait, where's my, what if we're not asking this, but we want to have a, so we're gonna get rid of all of this and get rid of this. And let's say we wanted to start this patient on oral theophylline. What would you suggest? So how are you gonna attack that? If we only knew this part here. Well, I would start, so do we want a loading dose? I don't know, but we can figure out a loading dose pretty easily, can't we? A loading dose is figuring out what your patient's volume is and getting it to that target concentration of wherever you're going. And then if there's any drug already they have on board, you have to consider that. You also have to consider bioavailability and salt form. Now, in this case, if we're just giving oral theophylline, we don't have to worry about bioavailability or salt form. And as far as we know, he doesn't have any drug already on board. And let's say our target is 12 milligrams per liter, just for the heck of it right now. So what's our loading dose going to be? It's going to be volume, which again, let's look here. Our volume is 0.5 liters per kilogram. So it's 0.5 liters per kilogram. He weighs 75 kilograms. So those kilograms will cancel and we'll have liters, which is a volume. So that's good. And what's our target concentration? 12 milligrams per liter. So those liters will cancel and we just have milligrams, which is what we need for loading dose, isn't it? I often go through the units first and make sure that it makes sense, because if not, I might have forgotten a component. Does that make sense?
Yeah.
So 0.5 times 75 times 12. What? Oh, you're not talking to me, right, Tom? So you're loading.
No, that was my son in the background, sorry.
Oh, hi, son. He sounds like you. Okay, so loading dose is going to be 450 milligrams PO for a one-time dose, and you may split that up. Let's see, how does it come here? Well, here's a 450, so you might be able to get 450, or you might have to, that's probably what I would do, is have one dose of 450 for oral theophylline, or you could split it up and do a 250 and a 200 or something like that. Okay, everybody good? We don't have to look at all these things that affect clearance, because clearance is not a component of determining loading dose, right?
So, Dr. Earle, so on this question, so if we were doing that 450 milligrams PO, would we want to split it up into multiple doses, or would we
Yeah,
want to do just
probably,
or with the
probably
extended release?
in
Okay.
real life, you're probably gonna do that, maybe give a 250 and 200 to, 12 hours apart or something like that. But you can't really have a patient do that at home, which you wouldn't anyway, so I think that's fine. I just don't want you to say 428. Do you know what I mean? When you can't give that, I want you to get used to like figuring out what actually you're gonna recommend. Does that make sense?
Yes, yeah.
Okay, so we're gonna give, so our loading dose is 450 milligrams of theophylline. And now what about our maintenance dose? So our maintenance dose, we'd come right back to good old CSS average, right? Where we're gonna have our bioavailable salt form of our dose rate all over clearance. And here again, we know our target is gonna be 12 milligrams per liter. We know we don't have to worry about bioavailability or salt form in this case if we're gonna give theophylline. And we're solving here for our dose rate, but we still also need to get a guess. This is gonna be a guess of our clearance, right? So how do we guess our clearance? Well, clearance, we know it for an adult is 0.04 liters per hour per kilogram. So 0.04 liters per hour per kilogram, and he weighs 75 kilograms. So we can, now we're on liters per hour, which is what we want to be for clearance, right? And then we're gonna look at any things that he has that will affect his clearance. So he has chronic bronchitis considered to be severe COPD. Okay, so severe COPD times 0.8. So we're gonna multiply this times 0.8. Pardon me. He also is a smoker, right? But he has normal liver and heart function, hypertension. Okay. So he's also a smoker, so that's 1.6. And I don't believe any of these other drugs are going to affect we're good, right? So we're going to calculate a guess of his clearance based upon his weight and his the other factors that we know about. So 0.04 times 75 times 0.8 times 1.6. I got 3.84 liters per hour. Is that what you guys got?
Yes.
Good. So then we're going to put that in here, aren't we? So we'll put in 3.84 liters per hour, which is just a guess, isn't it? It's an educated guess, but it is a guess. So I got, again, okay, we're going to be canceling out these liters. So it's going to be milligrams per hour, which is a dose rate. So that's good. His dose rate is 46 milligrams per hour of theophylline. Right? So I'm going to multiply that times 24 to get a daily dose. So I got 1105. So probably I'm going to recommend 1,000 a day to get to that 500 BID, which is how we got to that probably, right? So again, let's look and see what's available. We do have 500 milligrams available. So I would probably recommend 500 milligrams Q12 of theophylline. What if we were giving aminophylline? We would just divide this by 0.8, wouldn't we? Divide this by 0.8 to get aminophylline, since the salt form is 0.8 of theophylline. Do y'all follow that?
Yes.
Yeah.
All right, so I should be able to ask you to give a loading dose or a maintenance dose to start a patient on either aminophylline or theophylline. You should be able to figure out what the clearance is if we give you data, right? You all feel, you feel confident in being able to do that?
Yeah. As long as we have that sheet, I'll be good, I think.
And you will have it, so it will be attached to the exam. I just did it, so it'll be there.
Perfect.
All right, you good, Tom?
Yes, I am.
Okay, so this is the same case, and so now we know we had 30 milligrams per liter when we were getting 500 milligrams BID of theophylline PO. So suggest a regimen of theophylline to target a constant CSS of 12 milligrams per liter. So obviously it's too high. 500 milligrams BID is too much, right? So what I would do is, we know that CSS average is equal to bioavailable salt times dose rate all over clearance. And as long as all of this stays constant, then your CSS average becomes proportional to dose rate, doesn't it? So here's where we can say dose rate 1 is the CSS average 1, as dose rate 2 is the CSS average 2. Do you remember doing this last spring? Probably not, but you know, that's okay. So dose rate 1 in this case is is 1,000 milligrams per day. And our resulting CSS average, when we gave that much, was 30 milligrams per liter. So when we guessed back on this slide, well, I erased it, I guess, but when we guessed what his clearance was, which was 3 point something, obviously that was faster than his clearance actually was. His clearance is actually slower than that, because look, we got 30 when we expected to get 12, right? So now we can figure out our new dose rate if we put in here what we want the resulting CSS, oh shoot. Oh, okay. What the resulting CSS average we want to be, which is 12 milligrams per liter, right? So we're just going to solve for dose rate 2. Does everybody follow what I did? So when we gave this much, we got this as our CSS average. So now we want to know what dose rate we need to give of theophylline to get this concentration at steady state. Is everybody good with that logic?
Yes.
And it's not hard. You just have to remember what you're doing and why you're doing it. So 1,000 times 12 divided by 30. And we know it's going to be less than half, right? I mean, I just look at this, I'm going from 30 to 12. If it were 15, I could just cut that in half, but it's going to be less than that. And so what I got for our new dose rate is 400 milligrams per day of theophylline. Is that what you got?
Yes.
Yes.
So it's a nice clean 200 milligrams BID. Are you good? You probably could give 400 once a day, but I'd probably give it twice a day.
Yeah,
Just to
on the homework, it had us do BID.
what?
Oh, I just said on the homework, it did have us split it up to BID, so.
Okay, that makes sense. All right, you good with that? Are we ready to move on to another case? Do you feel like you can make these adjustments and all that?
Yes, I do. Yeah.
Good. All right, so we've got a little different case here now. So RT is a 48-year-old man with, again, severe COPD emphysema who's admitted with shortness of breath and a cough. He's 5'10", 175 pounds, has hypertension and COPD, which we've already noted. He smokes 2 packs of cigarettes per day and takes, so this one's not that different than our other patient. Little same age almost. Okay, recommend an intravenous loading dose of aminophylline to reach a theophylline goal of 15. So on this one, I think, is this the one I forgot? No, okay. Round to the nearest 50 milligram increment. Okay, so how are we gonna do a loading dose? Loading dose is pretty straightforward, right? It's just filling up a particular volume to a certain target concentration. Again, as far as we know, there's no drug on board, so we don't have to worry about that. We're giving it IV, so we don't have to worry about bioavailability. But since we're giving aminophylline, this target is going to be in terms of theophylline. So in order to get this loading dose in terms of aminophylline, we're going to have to divide it by the salt form, aren't we? You guys good with that?
Yes.
I'm kind of skipping steps, but hopefully we're good with that. So 175 pounds, which will get us to, so this is pounds and this is pounds per kilogram. So this will get us to kilograms. So that'll give us our volume, and our target is 15 milligrams per liter. We're going to divide that whole mess by 0.8. Is that what you guys got? Something like that?
Yeah, and I just rounded up to the 750.
And then when you round to the nearest 50 milligram increment, you're going to go to 750. Yeah. Easy peasy, right?
Not bad.
Tom, easy peasy?
Yeah, sorry. Kind of
That's okay.
people
I just
are
wanna make sure
contacting me
you
from
guys are
work,
with
so
me.
kind of.
Yeah, I know if you don't answer, I'm just gonna move on, but I do wanna, if you guys have any, I wanna give you a chance to jump in and ask questions. Here's where I messed up the key. I forgot to say round to the nearest whatever. I'll go back and fix it. I tried to fix it. I'm not that good at Canvas quizzes, so, but you'll get your points for this if you did something different than what I asked, so, because I screwed this up. Okay. Same case, right? But now calculate an intravenous maintenance drip of aminophylline to reach a goal concentration of 15. So now we're looking at our CSS average equation, right? Which is equal to salt times bioavailability times dose rate all over clearance. And again, our goal is 15 milligrams per liter. Our salt form is 0.8 because we're doing aminophylline. Bioavailability, we're giving a drip, so it's going to be 1, isn't it? We're giving an IV. Either way, the bioavailability is 1 times dose rate all over clearance. We haven't had to figure out this patient's clearance yet, right? So clearance for him is going to be, again, he's an adult. So we're going to use 0.04 liters per hour per kilogram. Times, I forget, we didn't actually calculate the kilograms, did we? We said 175 divided by 2.2. I might have messed that up, but this is the right thing to do. Okay, so there's that, and then we've got severe COPD, shortness and a cough. As far as we know, he doesn't have a viral, but you might look for a viral infection here. He also smokes 2 packs of cigarettes a day. Okay, so we have severe COPD and 2 packs of cigarettes a day again. So severe COPD is 0.8 and smoking is 1.6. Come on, baby. What's going on? done something to make this mad at me. Yeah, I can't advance. There we go. I got a clearance of 4.07 liters per hour. Is that what you guys got?
Yeah, yes.
Great. So multiply that times 15 and divide it by 0.8. And so I got a dose rate of 76.36 milligrams per hour. Yeah, liters will cancel. Of aminophylline. So we don't have to make any changes in that. And we're going to multiply that times 24. Well, if it's milligrams per hour, and what we're trying to get to report the suggested dose rate, yeah, 76.36 milligrams per hour. So I guess we're done. So rounded to the nearest 5 milligrams per hour. So that's why I wanted you to say 75 milligrams per hour. But I'm trying to change the key to accept, 75, 76, 76.4, 76.36. So if you got something that's acceptable like this, and I should have said round to the nearest 5 milligrams per hour, and then you would have said 75, right?
Is it similar to like, so what cutoff would we actually do to like round it up to 80? So if it was like 77.5 or higher?
Correct. Yep. Just
Okay.
rounding rules,
Okay.
And in reality, if it gets to be way far away of what you suggest, sometimes I plug it back into this equation to see what CSS average I'm going to get and make sure that it's acceptable. You know what I mean?
Okay.
So we could put 75 milligrams per hour here and put this clearance in of 4.07 and the salt form in of 0.8 and calculate what the CSS average is going to be. It's going to be a little less than 15, isn't it? Because we're only giving 75 versus 76.34. You know what I mean?
Yeah, that makes sense.
Tom, do you want me to set that up?
No, I see where
You're good? Okay.
Yeah, I'm good there. Yeah.
I usually do that so I'm ready when I talk to the team to say what we expect, so, maybe it's only, I don't know, this will be very close to 15, obviously, but if you have to make big leaps, because it's only available every 100 milligrams or something like that, you might go in and actually calculate what you expect this to be. What I always caution people to do is don't say that I expect it to be, 15.23 milligrams per liter, because of course we're only guessing, and if you say it to that degree of precision, they expect that, and we're not offering that. You know what I mean? So what we're offering is a guess, and I usually round it to something kind of big, like 15 rather than 15.23. Does that make sense too?
Yes.
All right. All right, one CF question on here. Given that Troy's goal is to eat 4 meals and 3 snacks a day, is this the appropriate number of capsules to dispense? All right, what does this say here? So we're going to give ZenPep 40,000. Do you remember what 40,000 means? Well, it's right here. Lipase per capsule. So even though we're giving lipase, amylase, and protease with these enzymes like ZenPep, this number is always the lipase number. Okay. So take 5 capsules with meals. So 5 times 4 for meals, he's getting 20 per day, right? and then 3 meals with snacks. So he's getting 3 capsules with 3 snacks a day. So for snacks, he's getting 9 per day. So he's getting 29 caps per day if he takes if he uses all of his meals and snacks. So if there's 29 caps per day, and there's 30 days in a month, in an average month, and we're dispensing a monthly quantity, we're gonna do 29 times 30. So he's gonna need 870 milligrams, or I'm sorry, capsules per month, isn't he? So you're gonna round that up to the nearest 100, because they come in hundreds. I don't know, did I say that? I probably should. So I would dispense 900 caps per month. So 800 isn't enough, is it? That's not hard, is it?
Nope.
So I think I told you I had somebody say, oh, you need fit. If you're getting 5, this is very specific, right? But if it said take 5 well, even actually the prescription did say this. Take 5 capsules PO, so with meals. So they said 5 times 3 is 15 times 30. And so they said, well, I'm only gonna give you 15 times 30. So I'm gonna give you 450 capsules per month, is what a pharmacist tried to tell me. And I said, well, that's not enough. And the prescription says 800, or whatever. And they said, well, no, you're trying to get more than you should from your insurance. I mean, he even said that to me. I
That's crazy.
about punched him in the nose. It took every ounce of my, discipline to not, I just walked out of the pharmacy.
Yeah.
Can't give me my prescription. You don't understand what you're doing, and left. But
Right. Especially since we know since they're at that hypermetabolic state, they're gonna want to eat them. They're gonna want them to eat more. So
we want, they to keep weight on them. Now with the new drugs, it doesn't. The new drugs have fixed so many things. It's not as big a deal, but we want to make sure that the most important thing for them is their well, not the most, but one of the most important things is adequate nutrition, so.
yeah. So Dr. Earle, like exam wise, I feel, okay with the math, like everything we just did, I feel good with.
Good.
Are your questions mainly going to be math based, or should I be knowing like the mechanical devices to use for cystic fibrosis and stuff like that too?
Say that again.
Like, should I also know like the mechanical devices, like memorizing like the rehab, like the percussion on the baby's back or the vest or
No, it's gonna be more pharmacy based. So I've got a little Kahoot we can go through if you want to. Would that be helpful?
Yeah, we can do that.
It's on CF specifically. Unless you have questions, but I think the last slide or the second to the last slide has all the things I really want you to know, and it's really it's pharmacy stuff, So like this, how to calculate the number of capsules to dispense. What's the maximum dose? So for this patient, if they're getting 40,000 units of lipase per meal, right? And he's getting 5 capsules, so he's getting 200,000 units of lipase per meal. Remember, you can't have more than 6,500 units of lipase per kilogram per meal, right? So if I told you the weight of this patient, you should be able to figure out if they're under this limit.
Wait, why did I have in my head that it was 6,000? It's 6,500?
I think it's 6,500.
Okay.
Go check it though. Whatever's in my slides is what I'll be asking you about, but I'm pretty sure it's 6,500.
Okay.
Yeah. So you should be able to do that. You should be able to figure that out. You should be, And if the patient is at the high end of that and you need more, like let's say you're close to 6,500 units per kilogram per meal, and they still are not gaining weight and they still have fatty stools and upset stomach when they eat, that means they need more lipase, and you don't want to cause a intestinal blockage. What we usually do is try to increase the pH so that the enzymes don't get destroyed in the gut as they go through. So you can give an H2 antagonist or a PPI to try to increase the pH, and that usually allows these drugs to work a little bit better because they don't get it increases their bioavailability basically. Does that make sense? So those are some things, making sure they have their immunizations, understanding, the different classes of mutations, and understanding the new drugs and the drug interactions that can occur with the new drugs. Understand what OTCs and other drugs you should avoid in CF patients and why. I forget what's all on that list, but those are the things I really want you to know. The pharmacist role.
Okay.
So let me see if I can get that Kahoot up for you guys. Shoot, I'm on the wrong thing here. Actually. All right, so go ahead to Kahoot and then put in the game pin of 25380, which I'm going to do myself here. Okay, I have to stop with that music. How do I get that off? Okay. All right. So you guys ready? I hope I made it so I control this. I don't remember if I did that or not. Okay. So. Why can't I see the question here?
We can't see it on our end.
You see, is it important that pharmacists check with all cystic fibrosis patients to be sure they are up on their immunizations?
Is red or blue? Yes.
Red is true. Red is true and blue is false.
Oops. I think the time limit passed, but I think that would be true.
But yeah, that's true, right? That's one of what I feel like is our role, is to make sure that they're keeping up with their immunizations. Why is this so weird on how this is sized? I don't know how to fix that. Okay, can you see the question at all, or are you seeing the same thing as I am?
We see the same
Yeah.
thing.
Same thing, yeah.
You see the same thing that I see? Well, maybe this isn't going to work. Let's try this next one, see what that says. Okay, the CFTR is responsible for this guy is, well, why don't you just tell me? I'll try to read them too. Moving chloride ions into the epithelial secretory cells, moving chloride ions out of the epithelial secretory cells, Moving sodium, well, we know it's not moving sodium, right? So we can rule out there's two moving sodium ions. And is moving chloride ions out of the epithelial or into the epithelial secretory cells? The the function of CFTR. Do you remember?
Is it out?
Yep, it's out because you're moving it out of those secretory cells to in the lungs. It's about really rehydrating those the airway surface liquids, right? I don't think this is gonna work. I don't know why this is, well, you know what, let me try. Let me see if I can change the settings or something that will allow me to.
I think it's because you're logged in on your computer to the like main host Kahoot thing.
Yeah,
It would have to be on the share screen for us to see the questions on Zoom.
yeah, but I have it on my computer at my desk, not on here.
Yeah.
That's probably why. Let me see if I can.
Sometimes it will show the question on our end, so I wonder if the settings, like you said, I don't know.
Let me just try to. Oh, here's the problem. I gotta look up my password because I just use it on here. Let's see, hopefully this will work a little better. You guys don't have to sign in. We'll just go, well, maybe someone will have to. Yeah. Oh, Tom. Okay, good. We're just gonna go with you, Tom. You guys don't have to answer. I just needed someone to sign in. Thank you for doing that. Okay. I think we can agree that that's a true, right? It's important that farmers, to me, that's one of our main roles. Everybody's good with that, right? All right, Tom. Here's that CFTR question. Right, so we can rule out these sodium ion ones because it really is about the moving chloride ions, and it's going out so that that chloride ion can do a better job of helping to hydrate, get the right components in that airway surface liquid. It's actually all of them, so that, not all of them, not increased. It's thick, it's green, and it's depleted. So all three of these should be correct. And so that one, I need to fix that problem. But you understand that if you think of that picture in showing how hypertonic saline works, and there's that little bit of airway surface liquid, and it's thick and it's green, it's icky, doesn't work correctly. A cystic fibrosis patient is encouraged to eat well, we know we can rule out these ones that are low in fat and protein. We want it to be high in calories, high in fat. So the more the better. Good. Tom, you're knocking it out of the park there. Which drug would you avoid in a cystic fibrosis patient? Guafenazine is actually okay, Tom, because that's just
Yeah, I realized that after I said it. Yeah, because
right.
It thins out the secretions to help them cough it out,
Right.
but you don't want to suppress the cough.
Correct. The cough is what we need to help the patient get rid of that gunk. Good. What do we want to make sure a patient takes with Trikafta? Remember, fat increases the bioavailability of these drugs, and so we want to make sure they have a fatty meal, make sure that they have some fat with when they take their meds. They take them twice a day, so you want to make sure it's with a fatty meal. We want to make sure that they avoid 3A4 inducers and inhibitors, especially inducers, because remember, this is like one of the most expensive drugs you can take. We don't want to inhibit bioavailability at all, and they are 3A4 substrates. So we want to make sure that we don't give a 3A4 inducer. Certainly, we don't want to give with grapefruit juice or St. John's wort, which also will interact with those 3A4 substrates, right? Everybody good with that?
Yep.
To me, that's another very important role of the pharmacist, is to know how to warn patients about those drugs and food and disease interactions. Yeah, it is true. It's not that they don't absorb any. Some patients do absorb some, but it's going to be harder because their pancreas does no longer provides any lipase, that it's harder to absorb the fat soluble vitamins A, D, E, and K. So we make sure that they are getting supplemental vitamins that are specific for CF patients, which include A, D, E, and K. Good. Questions? Are you good with all this, Jamie?
Yes.
Easy peasy.
Yes, ma'am.
Cystic fibrosis patients are hypometabolic, therefore their clearance and metabolism of drugs is slow. It's actually the opposite, isn't it? This is false. It's the other way. They are hypermetabolic, and therefore their clearance and metabolism of drugs is quickened, isn't it? So we often have to give higher doses and give them more frequently. Since clearance is increased, we're going to have to, in order to get the same CSS average, we have to give more drug, and their half-life is shortened, so we have to give it more often. We have to often give it longer too, especially antibiotics, because the microbes are more resistant. All right, Tom. Pancreatic enzymes are labeled with their what units? Yeah, lipase, good. Well, this is true. I don't know why I got that wrong too on here. All right, so I think you guys are good.
Wait, Dr. Earle, just in the slides, it does say 6,000. So should I
Oh.
change my knowledge to 6,500 or what will we need to know
No,
for the
stick with
exam?
the slides. Maybe it's
Okay.
I don't know. I should probably check that. In fact, I don't even know if the study that showed this is getting kind of old now, so I don't even know if it really holds. But I do think as you get to have these larger and larger doses, you have to be careful.
Right.
with
Okay.
patients. So, yeah. All right. I will use 6,000. So I apologize if I have confused people. And that's it.
Okay. As long as we know what to go off of, I think we should be good.
Yeah, I'll send a little note out to everybody to make sure there's not confused because I'm confused. So, all right. So I think we have a review in 5 minutes. Do you guys have any additional questions?
I don't think so. I feel pretty good about this stuff, so we'll
Good.
see.
How did you find the learning materials? Because I've not done a module before. So. Were you able to follow everything okay and feel like you got a thorough understanding?
Yeah.
Good.
Everything went good.
Good.
It was
All right.
kind of nice to have like a break with having videos rather than all the content written out. So that was nice.
All right. Well, I'm glad you like that. That's good. All right, guys. Well, thank you so much for coming and playing all the games with me here and going through all this stuff. And I will post this. You can let others know that if that this is there, if that's helpful to them. Okay.
Sounds good. Thank you, Dr. Earle.
You guys.
Yeah, thank you.
Bye-bye.